Hey, I'm Dobbin Chow. I'm the program director and the chair of medicine here at the University of Maryland Medical Center Midtown campus. I want to welcome you to the internal medicine clerkship rotation here based at the Midtown campus. I'm very happy to have you all here. We're excited to host you, and we hope that this will be a wonderful educational experience for you. I've listed here my email and my cell phone number. I'm very accessible by email. I check it several times a day. My cell phone is also on all the time, and feel free to call me or text me if I can be of any assistance. I hope that you'll feel comfortable doing that. I'd rather hear from you if there's any questions, any issues earlier than later, because we want every day here at Midtown to be an enriching, fulfilling, and educational day for you. So what is Midtown campus? So on a good day, we're a 200-bed community teaching hospital. I think some days we're less than that. These beds include also psychiatry beds, a post-acute unit. So the total number of medicine beds is much less than 200. Now, University of Maryland Medical Center is the combination of the downtown campus and the Midtown campus. And together, the two campuses form one institution with two campuses. So we are affiliated with University of Maryland School of Medicine. All the faculty with whom you will meet and teach and mentor with are all full-time School of Medicine faculty. We have here two separate residency programs. One is the internal medicine residency program composed of 9 residents a year, so it's a total of 27 residents. And then we have 10 residents in a PGY1 transitional year program, so a total of 37 residents. In addition, we have 6 students from the American University of Antigua College of Medicine here on their medicine clerkship year-round. Now, before we get too far, I just want to remind you that we're here in Baltimore, and we want you to pay attention to any safety and security needs that you might have. If you park at the parking garage, which you're welcome to do, then you walk directly from the hospital into the parking garage, and it's or vice versa, and it's usually fairly safe. If you want to do that, you can purchase discount coupons for the parking, and we'll tell you how to do that on your first day here. On the other hand, people have chosen to take the shuttle. There's a shuttle between the downtown campus and the Midtown campus, runs every 15 minutes. Also, people have ridden their bikes here. But if you're going to be out and about in the neighborhood, I'm going to remind you to not wear your white coats. Also remind you not to be on your phones. And also remind you that if you do park your car, that make sure that all your valuables are in the trunk, out of sight. We fortunately have not had any students experience any security problems, and but we want you to take precautions nonetheless. Okay, so the first day, we're going to meet you in the lobby of the hospital. I'm going to though tell you about the conference room because on the first day they're probably going to take you to Department of Medicine and get you take some administrative issues squared away. But if they tell you to go to the resident conference room, it's on the 5th floor of the hospital, and the hospital is very easy to navigate. It's just basically on one long spine, and it's north-south. So you go to the 5th floor, and you go in the south direction. At the very end, you'll see this door, and it says the Adult Psychiatric Day Hospital. But it's no longer the Adult Psychiatric Day Hospital. That exists if you go to the right immediately after you enter this doorway. But if you go to the left, there's the conference room. And you see there on the wall, there's this badge system. You just put your badge up against that badge reader, and then the door will unlock for you. And then when you go through that door, then this is looking at the conference room from the rear, and this is where we have conferences in the morning, noontime. If you look to the back of the conference room, there's a table. The table is where usually lunch is available, and beyond the table, there's some chairs, a little coffee table, a water fountain, and it's a place where you can sit and rest and read. It's usually quiet there during times when there's no conference going on. Now, you'll be assigned to the purple team, and the purple team is located on the 4th floor in this, and again, it's the 4th floor. There's a 4 north and a 4 south. You go to the 4 south at the end of the hallway, and you'll see this room on the left side of the hallway. It says conference room. This is the purple team conference room. You'll see there's a keypad there to get into the door, and I'm showing you on the screen here the combination to that keypad. It's 8790. You press that, it'll unlock, and you can enter the door. And this is the team room. When you go into the team room, there's a set of lockers there, and you're welcome to use any of the lockers. They're there for your use. It's a combination lock, which I'm not exactly sure how it works, but I guess there's some instructions there, and you can lock your things in these lockers. I would though still recommend that you carry your wallets and valuable items with you. Now, we have a library here. The library is on the 4th floor of the Armory building. It's another building. It's called the Armory building. It's at the other end of the hospital, and you can the Department of Medicine's on the 3rd floor of this building. On the 4th floor is this library, and if you see a key lock, push key lock device there, and the code there is BOOK. Now, so you got to look on your phone to find out what numbers BOOK correspond to, but you press BOOK, and then this door will unlock. And so this library is open to you 24/7. Now, during the daytime, there's a librarian there, and this door will be open. The daytime being from 9 to 5. But outside of those hours, you can press the keypad and you can gain entrance. BOOK, and then when you enter, there's some computer stations there, and you can do charting there. It's usually quiet. There's also books, as there is wont to be in the library. And this is a shelf of books that is primarily for medical students to use. And I call your attention to these 2 books, IM Essentials and IM Essentials Text and the Question booklet. These are published by the American College of Physicians. This was the text for the internal medicine clerkship for all the clerkships all over the country. It has been updated, has not been updated in quite a few years, and so it probably needs to be updated. But right now, these are it's a good text. It's pretty comprehensive, and you'll find a 3 or 4 page chapter on almost every disease condition in internal medicine, and then there's some questions related to the text. This text is written at the 3rd year clerkship level. Another book that I like to recommend is this book on the bottom shelf, Symptom to Diagnosis. It's part of the Lang series. It's also at the medical student level, and very well written, and it's very helpful for you, and as you go and try to make an assessment on your patient, and they present with a symptom, and it helps you elaborate what might be a reasonable differential diagnosis. So you can, I guess it's sort of a cheat sheet, a cheat book for your assessment and plan. Okay, so at the other corner of the library, there's some chairs you can look out. You can ponder the mysteries of internal medicine. On a nice day, you can see pretty far out into the city. There's on the 2nd floor of the hospital, in the main part of the hospital, there's a lactation room if you need it. Now, this is also, there's a key badge mechanism to open the door, and but it won't open for you unless you get security to give you badge access. You'll have to go to the security office and check in with them. And then they'll grant you the badge access, and you can use this room. Okay, so how are our ward teams organized? So this is you'll be on the purple team. Here's a picture of the purple team. There'll be an attending, a resident, 2 interns, and 2 students. These are all the ward teams here at Midtown. So the purple team is what I just described. There's also a gold team, similarly with 1 resident, 2 interns, 2 students. These 2 students on the gold team are from American University of Antigua. There's an orange team, which is 1 resident, 1 intern, 2 students. This orange team, they are responsible for the intermediate care unit, the IMC. There's a night float team, which is 1 resident, 1 intern, and 1 student. And now admissions. So you'll receive, your team will receive admissions. The teams accept admissions on a serial basis, so your team will get admissions every day. But on any given day, a different resident is on call. Your resident will be on call approximately every 4th day, and they are called the MAO. Now, on any given day, 1 intern is on call. On any given day, your intern will accept up to a maximum of 4 new patients. They usually don't get up to 4 new patients, but that's the cap for them. And but your intern will probably get at least 1 or 2 new patients each day, and so the potential exists for you to be able to get new patients. That's not going to be a problem. Now, in the morning, you'll come into the hospital in the morning at 7 in the morning, and the night float team will be distributing the patients that they worked up overnight. And so some of their admissions might go to the gold team, some might go to the IMC team, the orange team, and some might go to the purple team. And so that's one way for your team to also get new patients. New patients can come from the emergency department, either from Midtown Emergency Room or the downtown emergency department, the night float team, as I mentioned, or as a transfer from the ICU. Now, if the patient comes to the purple team from the night float service or from the ICU, these patients will already have had admission note. They already will have had admission orders. The ICU transfers will also have had progress notes and a transfer note. And so there's these patients would be relatively worked up. Someone will have, someone from internal medicine will have laid eyes on them and come up with an assessment plan. Patients coming directly from the emergency department, well, the emergency department will have performed a workup, but these patients are relatively more early in their workup, and they might be more challenging and more productive for you as a student to get involved with patients coming out of the emergency department. The ER is focused mostly on triaging patients, attending to their most urgent problem, and you can make a more detailed assessment of the patients. Maybe come up with a little bit of a different assessment, and so that might be a more appropriate patient for you all to see. So night float, as I mentioned, they accept up to 5 admissions overnight, and then admissions are distributed each morning. Now, when you're on call, and you should be on call with your intern, and it should be about every 4th day, so it's not every day. And when you're on call, you stay until about 7 p.m. If you don't pick up a new patient by 6 p.m., then don't try to do that, because your residents will be leaving at 7 o'clock. At 7 o'clock is when they sign out. So usually you should probably almost 99% of the time be leaving the hospital around 7 p.m. when your team signs out, but when they're on long call. And under no circumstance, absolutely, should you stay past 9 p.m. So students, as I mentioned, should prioritize new admissions for the emergency department rather than work up patients who are transferred from night float or from the ICU. And it's not necessary to come in on weekends. All right, what are the student responsibilities? Well, we want you to take a proactive role in answering this question. I know some of you will have had some experience on the inpatient services. Some of you are coming fresh out of the basic science courses, and so there'll be varying degrees of experience, and that's fine. There's no expectations around what your experience level should be. We encourage you to seek out and from your attending what they expect in terms of your presenting style, and what your residents expect, what the interns expect, and so you have to be proactive and ask them. They've been told to be proactive and to ask you and speak with you, but sometimes they forget to do that. So I encourage you to be proactive and tell them what works best for you, and try to meet or exceed their expectations. You should also ask. They might ask you to give a presentation on a topic, and maybe it'd be a 10-minute presentation on a topic that arose in the course of the day. Ask, hey, do they want a handout? Do they want a PowerPoint? What would be the what will work well? So be proactive about finding out what the expectations that the team might have for you. The common expectations are you're not expected to know everything. Don't feel like you have to know everything. The internal medicine is a daunting specialty. That's why it's so much fun, and it's challenging. In fact, I think a better tact might be for you to demonstrate to the team not what you know, but what you don't know. And how do you do that? You ask questions. Ask, hey, tell me more about this disease. I don't know much about it that you are all discussing, or I don't know much about that medication. Or and be proactive about this. Don't think that because they brought up a topic, brought up a point in discussion, that you necessarily are supposed to be aware of it and have learned about it. So ask questions. That will show the team where you are in your learning process, but also will show them that you're engaged, that you're interested, that you're a proactive learner, and that will help them with provide you with additional future learning opportunities. Learn the disease as well related to your patients. Now, what does that mean? The patients will come in with a disease process. Go home, read about it, and that material will come alive for you. Why is that? Because as you're reading it, so for example, a patient came with asthma, and as you're reading that chapter on asthma, you're going to say to yourself, oh gosh, I forgot to ask about occupational history. Or you say, oh gee, wonder why my patient's on this medicine and not that one. And so you'll read this material through the lens of your patient, and that material becomes solid. It becomes a brick of medical knowledge that will, and as you build your foundation of knowledge brick by brick by brick, you'll amass a solid foundation of knowledge. You're not going to learn all the diseases of internal medicine, but you'll learn the common diseases, but it'll be on you to go home, read about them, learn them well, and your patients will be the ones who will help you in this process. Know also your assigned patients well, meaning you become the expert on your patient. Your resident will know that your patient has diabetes. The intern will know that the patient has diabetes and is currently being treated with long-acting and short-acting insulin. But you will know, hey, the patient has had diabetes for 18 years, was initially treated with metformin. After 5 years, the patient was transitioned to metformin plus another agent, and then after 3 years was then switched to insulin, and the patient was hospitalized these many times for diabetes. So you become the expert on your patient, and why is that helpful? One, it's helpful for the team as you're discussing the patient during rounds, but also it helps you learn the natural history of disease, how the treatment for a particular patient might evolve over the course of time, and how a disease process might evolve over time. We want you to develop a systematic approach to evaluating new patients. What does that mean? That means that if they give you a patient in the emergency department with a symptom, that you will approach that patient using a systematic approach. And here's that approach. I'm not sure if you've seen this acronym. There's other acronyms that are out there. I've heard of an acronym called P vitamins. Basically, you rearrange these letters, you can come up with P vitamins. But so I'll give you an example. Suppose the patient was admitted with chest pain. Then the temptation is to go straight to vascular as the etiology of the chest pain, and you can discuss the vascular causes of chest pain. But in a rigorous way, you can say, hey, it could be vascular, but also could it be infectious? Could the chest pain possibly have a neoplastic origin? Is there a degenerative disease? Is it iatrogenic, congenital, or inherited? Is there autoimmune etiology? Toxic metabolic possibilities, endocrine. So if you go through this each time, every day, with every patient, you won't go wrong. Where you might go wrong is you come to premature closure on one of these systems and neglect the others, and that's where you may go astray. So if a patient comes in with a very rare condition and you've never heard of it, and your resident hasn't heard of it, that's fine. You take those symptoms, you go through this process, and you won't go wrong. Or who knows? You'll come up with a diagnosis. So we encourage you to be involved in the care of your patients, accept responsibility for the care of your patients as much as you feel comfortable doing. So if someone needs to call the patient's son in Philadelphia and update the son, volunteer to do that if you feel comfortable doing that. Someone needs to call the primary care doctor to find the list of medications the patient's taking, a volunteer to do that. If the patient asks you, hey, well, what is my prognosis? And you're not sure or you're not comfortable going there, that's fine. Just call a timeout, tell the patient, hey, thank you for that question. Great question. Let me check with my team. Let me get back to you. Don't put yourself out there in a place that you feel uncomfortable. Now, medical students should write notes on the patients that you worked up. Write them in the student notes section in Epic. I think hopefully you all know where that is. You write up your new admissions and with a detailed admission note, and then also write daily progress notes using a SOAP format. You can use templates, and the residents will be glad to share templates with you if you don't already know of a student template for your notes. Don't send your notes to the resident or attending for co-signature. They don't like that. Their inbox is already cluttered with a lot of stuff, and they won't know how to manage it. But we do want you to get feedback on your notes. So you grab your resident or your attending by the scruff of their collar, sit them down next to you and go over the note, or you can print them out and then take it to the resident or the attending and ask them to go over it with you. We definitely want you to get feedback, but don't send the notes for co-signature. Also, don't pen your notes if you're in the middle of writing a note and then you have to go for a conference or rounds. That's fine. Just sign off on your note, and then later on come back and then do an addendum. Don't pen it. And we want you to seek feedback on the notes. The resident, be aware that the resident will write progress notes in the chart as well. Don't use their notes as gospel. Goodness knows the student notes are much more thorough, detailed, accurate than the resident notes a lot of the time. Now, there was this act of Congress called the Cures Act, and granting patients access to their charts. So any progress note, consult note, admission note, discharge summary, they will be released to the patient as soon as signed or co-signed. But patients also have access to laboratory, radiology, pathology reports. But what about student notes? Well, if you write a note using the medical student note, it will not be released because the student notes are used for educational purposes. So generally, they're not released. So this is the top of the student note, and I'm calling your attention to this line here, which says co-signature required. If you check that box, then a co-signer will need to be populated in this box with the exclamation mark. I'm trying to encourage you, don't send your note for co-signature, so the co-signer box will not be required. Now there's a tab here in the upper right corner. It says share with patient. If you click on that, then it will be sent to be available for the patient to review. we encourage you not to check that box, and the patients will not have access to the student note. Okay, during rounds, be proactive, ask questions, participate actively, volunteer to answer questions that arise on the rounds. If no one knows the answers to questions, volunteer to look up those answers. Be compassionate to the patients and their families. Be respectful to the staff, and beware of privacy. So if there's 2 patients in a room and we have 4 or 6 beds in which there's 2 patients in a room, then make sure the curtain is pulled so that there's some privacy. And then pay attention to isolation precautions. Wash your hands going in and out of the rooms, using gowns and gel appropriately, and also be sure to wipe your stethoscope between patients. Rehearse your presentations before you give them. That will be helpful for you to improve your presentation skills. It's not an exercise in reading your write-up. It's an exercise in you presenting your case, making an argument for your assessment plan. So be confident, take ownership of your material, speak clearly, and it will make a difference. And we will want you to get some feedback on your presentations. And by the end of the rotation, we want you to feel confident in your presentation skills. Over the course of the month, be sure to pay attention to your required to read the required reading. You want to be sure you're doing some reading every day. Establish some goals regarding your reading. I used to tell students to carry index cards around with you. Now, you guys probably never seen an index card. They're these little white cards, and you put them in your pocket. And let's say that you're on rounds, and you the intern asks a question about hey, should we start this medication? And the resident says, what's the QT interval? And you scratch your head and wonder, why is that an important question? So you just write this down on an index card, go home, you read about it, you learn that antibiotic can prolong QT interval. That becomes a little kernel, little nugget of information that gets stored in your memory bank. And soon you'll have a lot of these little nuggets that you'll carry around with you. Focus your reading on differential diagnoses, because that's what the patients come in with. They don't come in necessarily with one diagnosis, but with symptoms. And then you have to formulate a differential diagnosis. As I mentioned, this the Essentials textbook is a nice textbook, and you may want to peruse it when you're in the library. So this is something that we want you to do here at Midtown. Okay, I can see you're getting a little upset about this. You're doing enough work as it is. Look, I know how it is. We're not asking you to do a whole bunch of extra work. All right, now listen. First, we want you to give me 2 copies of your admission notes. These are not the admission notes that you wrote up and you're going to send to Dr. Goyle downtown. These are admission notes that you wrote in real time. They should reflect the work that you did that night. Don't go home and buff them up, and don't type them out. For goodness sake. Just make copies of them, put them into the portfolio, and then take 2 progress notes that you wrote and put them into the portfolio. And I like to see those notes see your admission notes, and it helps inform the quality of your work, the detail of your history taking, detail of your physical examination skills, and then how you formulate an assessment plan. And then if you give talks to the team, then give us a copy of the handout that you handed out, or the PowerPoint presentation that you gave. Put that in the portfolio. All right. So those are things that you're doing anyways. All I'm doing is asking you to just put in the portfolio, right? So not a lot of extra work, right? Now, this one extra thing I like you to do is something called a patient follow-up note. Okay, so you tell one of your patients that you would like to follow up with him or her after the discharge, and then you confirm with them what their phone number is. And this is a person who's going home, not to a nursing home or to a rehab unit. Then you call that patient 2 to 5 days later, and you ask them, "Hey, how are they doing? You go over their medications with them, go over their prescriptions, go over their follow-up. What is the status of their breathing now? How's that leg feeling now? Whatever it is that brought the patient in." And then just write a couple of paragraphs. The first paragraph will be hey, we admitted a patient with cellulitis, and the patient was discharged to home on this antibiotic. And then the second paragraph will be what you all talked about. And then the third paragraph will be just what your impression is of that experience. Did it help patient care? Did it improve what the patient felt about the patient, his or her experience? And students have found this not only to be helpful for the patient in terms of making them feel still connected to the care team, but also, what percentage of the time do you think the patients are taking the medications that are listed on their discharge summary? Well, if you said about a third of the time, you'd be right. And so this follow-up phone call often catches errors. So I'll give you an example. One student called because the patient was discharged home after pneumonia on an antibiotic. The student called and said, "How are you doing?" The patient said, "I'm getting worse. I think my symptoms of pneumonia are coming back." And the student said, "Hey, you're taking that antibiotic, aren't you?" And the patient said, "Are you kidding me? I can't afford that antibiotic. It was $800. So the patient never got that prescription filled. So the student found the resident. They contacted the patient. They contacted the patient's pharmacy. They prescribed a medication that was generic and inexpensive. The student later called to confirm that the patient got it, and then a few days later, the student called just to see how the patient was doing, and the patient was feeling better. So that was a important phone call. The student was able to avert a readmission. There was another example where the student called the patient who was being discharged on warfarin, and the patient was supposed to follow up with her primary care doctor about getting the INR checked related to the warfarin dosing. The student called the patient, and the patient said, "Oh, my doctor's on vacation. I can't get an appointment until 2 weeks." And the student said, No, 2 weeks is too long. You were supposed to get a INR within 3 days of discharge. So the student called the doctor's office, and indeed the doctor was on vacation, but the receptionist said, "Gee, if the patient told us that she needed a INR check, she could have come into the office, and we could have drawn the blood and taken care of that. That the doctor didn't need to be here for that." So the patient went in, got the INR check. Turned out the INR was subtherapeutic, was low. So the dose had to be increased a little bit. But if the patient had waited for 2 more weeks for the doctor to return from vacation, goodness knows what could have happened, as the patient was subtherapeutic in her INR. So here, the student was able to avert a complication. So these are important examples, but there's a lot more. And what you'll come to learn is that the most dangerous part of a patient's hospitalization is the discharge and the transfer from the patient from the inpatient status to either home or the nursing home or the subacute unit. That handoff can be potentially a dangerous one. Okay, we encourage you to ask for feedback. Be sure to do it on a regular basis. Have them, their attendings, the residents, they know that they should give feedback. They've been taught how to do it, but sometimes they're busy. You have to be proactive, ask them for it, and when you do, be specific. Don't ask, hey, how am I doing? They'll pat you on the back and say, you're doing great. Instead, be specific. Say, how did I do on my presentation of my patient this morning? Should I have included more in my assessment plan? Or, hey, here's my write-up. Can you go over it with me? Talk to me about how I might be able to improve my my mission notes for the future. And they'll be glad to do that. They'll sit with you after they do that, thank them for it, and they'll be glad to engage you in another feedback session later in the month. So please attend all the clerkship activities on time. If you need to be absent, that's fine. We understand that life goes on. Just let us know, and let your resident know, and we can communicate with the office at the downtown site. In terms of dress, I don't know what to say anymore. If you want to use scrubs, you're welcome to use scrubs. But if you do, please wear scrubs up and down, top and bottom. But I think students have dressed very professionally up till now. So I guess you all have been instructed on what professional dress looks like. Okay. Now, there are recommended conferences and required activities. So the one required activity for you all is the attending rounds with the Purple team each day, and that's in the morning. Now, there are other conferences that are being held. We have morning report every day. We have morning report for students every day. It's at 7:00 in the morning in the conference room, and there the night float student will present a case that they worked up overnight, and then we all get a chance to ask questions, dissect the case, discuss the assessment and plan and differential diagnosis. It's at the student level, and hopefully you'll find that interesting and educational. On Tuesdays, it's usually a resident who presents a interesting case, to the students. New conferences are held at noon time every day. All the residents go. There's usually a lunch, so that's that can be helpful. But there's usually a topic that's hopefully will be of educational value for you all. In addition, there's a palliative care case conference held by Dr. Carla Alexander every other Monday from 1 to 2. And I do some teaching rounds on Monday afternoons. It sometimes is after Dr. Alexander. If Dr. Alexander is not doing her conference, then I will start at 1:00. Now, why are these recommended here on the left? Okay, and that is because these sessions are attended by the students from the American University of Antigua. The LCME, the accreditation body for medical schools around the country, they do not want non-LCME school students to have the same educational experience as LCME students. So they said that it's that we cannot require you to be at conferences or educational sessions which there are non-LCME students. So because the AUA students are from a non-LCME school, then we cannot require you to be at these conferences. However, I think these conferences are of value, and we hope you'll consider attending them. But they're not required for you. Please consider joining the American College of Physicians. The website is here. The American College of Physicians is the professional organization for internal medicine. All the specialties have their own professional society. There's American College of Radiology, American Academy for Family Physicians. There's American Academy of Pediatrics. But by far, you heard it here, by far, the best organization is the American College of Physicians. And I have to pay $540 a year to join, and you can join for free. And there's a lot of activities here in Maryland for students. And also there's a newsletter that you'll get. You get access to the Annals of Internal Medicine. And there's also opportunity to present cases and scholarly work at various meetings. So please join, and I'm sure you'll find something enriching and enjoyable and educational with the ACP. So the IM Essentials text and the IM Essentials questions, I showed you a picture of those two books. I suggest using those as textbooks to read. However, please supplement with additional readings related to your patients. The IM Essentials text is at the third-year medical student level. I know that you have access to the simple cases. These are in Aquifer. These are excellent cases. They're complementary to the IM Essential text, meaning the material covered in the simple cases correlate with the IM Essential text. They're excellent cases. I encourage you to do them. They're great learning opportunities, and I think you'll like them. Very well done. Be sure to submit your mission notes and CEX exam down to the Department of Medicine at the medical school, but submit your portfolio here at the end of the rotation. Okay, just going to finish up with some examples of how students have been effective. I say this because I never want to discount the importance of the student to the ward team. They are integral to the functioning of the ward team. So I had a patient with advanced breast cancer, and the decision was made to make her palliative care, and she was going to be transferred to an inpatient hospice facility. So this was at the end of a pretty harsh winter here in Baltimore, and they were trying to find a hospice facility for her, and because she was palliative care, the residents would go in every day, just say hello to her, make sure that the pain was under control. But they weren't checking on X-rays, laboratory tests, and so the main question they had for her was pain. And she would say the pain was okay. They would walk out, and so they would not spend a lot of time with her. But the student came in every day, sat with her, and not only talked about her pain, but also talked about the impact of the breast cancer on her life, on her family, talked about her life at home. And then there was one day in which we finally had a warm day. It was sunny, and the student said, "Hey, it's a nice day outside. Sure would be nice for you to get some sun and some fresh air." And this patient had not been outside in 2 weeks. Now, nurses cannot take a patient off site for some fresh air, because the nurses have to get someone else to cover them, and the nurses they don't like to do that unnecessarily. So, so the student got a wheelchair, put the patient in a wheelchair, wheeled her out, and they were in the towards went down to a part of the hospital which was outside. It was quiet. She got some sun, and they sat for about 20 minutes, 30 minutes, and then he brought her back to her room. And the next day she went to hospice, and a couple weeks later she passed away. Now, how do I know that? I got a letter from the family, and with that letter came a check. And the family wanted to endow a lectureship and the name of this medical student regarding treating patients with compassion and humanism. Now, it was not a big check. The family was not well-to-do, but it was very meaningful for us, for the medical student. And it was clear that the student, that the interaction of the student with the patient was very important to the patient and their family at the end of her life. And so so that was a very nice thought, and it's a nice way to honor the memory of their mother. I had another patient who had CML. Now, I'm not an oncologist, and I don't know much about CML, but we admitted a patient with CML. And this patient was Philadelphia chromosome negative CML. Now, there wasn't much that can be, and I came to learn there wasn't much that can be offered to patients who are Philadelphia chromosome negative in terms of therapy. Now, the medical student took on the case, and she presented a wonderful talk to our team about the Philadelphia chromosome, the importance of this chromosome, and how it impacted the treatment, and so I learned a lot about genetics of CML. In the course of her reading, she came across a oncologist at the NIH who had written a good deal about this Philadelphia chromosome negative CML, and so she emailed him, and she said, "Hey, we got a patient here in Baltimore, Philadelphia chromosome negative. Are you doing any clinical trials to help? Maybe there's some treatment opportunities for our patient." And so this doctor wrote back to her and said, "Yeah, we'd love to see him. We might be able to provide some treatment opportunities." And so, well, we gave that information to the patient. And when he was discharged, he was going to go down to NIH and visit with this doctor. So this student not only served in an educational role, providing education to our team, but also she found a potential mechanism for the patient to receive some treatment. Now, I had a patient with pneumonia, and this was not our finest moment. This was a young man. He had pneumonia. He was in a room with a roommate, it was a semi-private room. And the medical student, she was going in to see this patient's roommate. She was assigned that patient to see, but she was very friendly. And of course, the roommate and my patient, they were, I guess they ended up talking a lot over the course of the day, as patients do. And so the student got to know my patient as well. And so one day we were making rounds. We came in and we said to the patient, "Hey, you're doing great. You're responding to the antibiotics. Your pneumonia's turning around. We can take off the oxygen. We're going to send you home on antibiotic pills. Antibiotics you can take by pill." And we said, "Hey, this is wonderful. Do you have any questions?" And he said, "No." And I said, "Great." And so we're all getting ready to leave, and the patient pulls at the sleeve of the patient. Pulls at the sleeve of this medical student, and says to her, "Hey, what's pneumonia?" And it turns out the whole time, we have been using medical jargon, and he didn't understand. And it turned out the patient is illiterate, but as patients who are illiterate tend to do, they cover up their illiteracy, and they don't acknowledge it. And if it wasn't for this medical student's relationship with this patient, the patient would have been given all these discharge handouts, given prescriptions, and I doubt that he would have taken the antibiotic. But the patient had enough connection with the student that he felt that he was willing to disclose to her his vulnerability. And I think that's a wonderful example of the connections that students can build with patients. So the student went back, sat with the patient, talked to him about the pneumonia, and what it was, and the importance of taking the antibiotic. And I think that led to a successful outcome. Lastly, we had a patient with alcohol withdrawal syndrome, and unfortunately, our patients here in Baltimore, they sometimes have a tendency to indulge in drinking too much alcohol. The one time our student was sitting next to an intern. The intern was admitting the patient, and what happens is the patients get put on something called the CIWA protocol, CIWA. And this is an acronym that stands for something that I can't remember right now. But at any rate, the student said to the intern, "Hey, what's the CIWA protocol?" And the intern said, "Oh, it's great. The nurses do all the work. They score the patient based on withdrawal symptoms. Then they'll administer benzodiazepine, and they will dose it based on the patient's score." And so it sort of leaves the residents out of the loop. It's sort of an autopilot, automated way for the nurses to manage the alcohol withdrawal and keep the patient out of withdrawal symptoms. Well, the student went home and read about the CIWA protocol, and it turned out it originated in the nursing literature. And what happened was a hospital used it. The nurses liked it, and the patients seemed to do well. So they published it in the nursing literature, and then before long, it caught on like wildfire, and soon all the hospitals around the country were using it. And so I thought that was an interesting story. That it didn't, even though it's widely used, it didn't originate from a robust evidence-based approach. It was somewhat anecdotal when it first caught hold. So I asked the student to make a presentation about this, and she did, and she presented it at Morning Report. But just an example that I encourage you to not always necessarily ask the question, what should we do? But why do we do it? And the residents should be on point with answering that question. And if they don't know, they should look it up. Why do we use the CWEL protocol? So you'll be evaluated on the 6 core competencies, and I'm sure you've seen this before. I think you get evaluated on the 6 core competencies with all your rotations. Okay, so just some final comments. Be yourself, relax, enjoy yourself, have fun, be proactive about asking questions, and we hope that you enjoy internal medicine. It's a wonderful specialty, and it's a good way to make a living. So I hope that this is a specialty you'll consider. And if not, enjoy learning internal medicine. It will serve you in all the specialties that you take. In terms of inclement weather, we follow the School of Medicine cancellation policies, but don't take chances if it's unsafe. If you feel then don't come in, and just let your team know. All right. So thanks very much for your attention. I look forward to meeting you. Look forward to working with you. And best wishes on the rotation. Thanks. Bye.